Okay, welcome to Internal Medicine Ultra Rounds. Thank you everyone for joining despite the last minute time change. So I really appreciate you guys being here. Today we have Dr. Maytham Husain and Dr. Maria Tauqir presenting a case-based discussion on the venous excess ultrasound, or the VExUS study, or the VExUS scan. And so this will be a quite interesting discussion, some nice pictures to see, I think. So I'll pass the mic over to you guys.
Perfect. Okay. So first we'll start by describing a patient case that we were involved in this past month, and we'll use this case to discuss the principles of VExUS, how to obtain it, and then ultimately how to apply it by circling back to our case. We'll then discuss some of the caveats and limitations of VExUS, and then finally we'll discuss another case just to consolidate everything that we reviewed. And then we'll open up the floor for questions and discussion. So Miss GU, she's a 78-year-old female from Home Alone in London, who presented with diffuse abdominal pain and hypoxia. And as you can see from her past medical history that's listed here, she is quite comorbid. She does have a history of multifactorial pulmonary hypertension with minimal RV failure, NYHA class 3. She is followed by Dr. Mehta, who believes that this is likely pulmonary arterial hypertension and inoperable CTEPH. She has been noted to have multiple bilateral pulmonary emboli on previous imaging. With her most recent echo that's on file, she was noted to have an RVSP of 35 to 40 millimeters of mercury and moderate TR. She is on 4 liters of HOMO2, and she is on Bosentan for her pulmonary hypertension, as well as Lasix. She was previously on 80 milligrams once daily, but then several weeks prior to her presentation to hospital, this was reduced to 40 milligrams once daily. She's also noted to have presumed invasive pulmonary aspergillosis, which was noted on bronchoscopy in June of 2019. She was treated with 3 months of voriconazole. Since then, she's had persistent pulmonary opacities, which are presumed to be COP, for which she is on prednisone 30 milligrams once daily, as well as septra prophylaxis, and she was compliant with this prior to her presentation to hospital. On her May 2022 echo, she was noted to have MR with LV diastolic dysfunction and a preserved EF of 65 to 70%. She also has asthma with an FEV1 of 79% noted on PFTs in October 2021. She does have AFib as well, for which she's on warfarin, digoxin, bisoprolol, and diltiazem. And then she has a bit of a malignant history here. So she did have diffuse large B-cell lymphoma and completed 3 cycles of attenuated R-CHOP chemotherapy, but this was then stopped due to worsening pulmonary hypertension. As per her most recent assessment, though, she is believed to be in remission. She otherwise had a left breast tumor for which she went a unilateral mastectomy in 2016 and thyroid cancer with a left hemithyroidectomy in 2000. So she presented essentially with a several-day history of progressive shortness of breath on exertion, NYHA class 4, so up from her baseline of 3, and diffuse abdominal pain with constipation. She was noted on presentation to have a low-grade temperature of 37.9. She was slightly tachycardic and had increasing oxygen requirements from her baseline of 4 liters to 6 liters. On physical exam, her JVP was noted to be 5 centimeters above the sternal angle with a positive hepatojugular reflex. She had bilateral diffuse inspiratory crackles, more prominent in the middle and lower lung zones. There was no pitting edema noted. And then finally, she was noted to have a loud P2 on cardiac auscultation. Her investigations were most notable for a leukocytosis of 14.9 and an AKI with a creatinine of 124, elevated from a baseline of 95. Her ECG did demonstrate AFib with PVCs, but she did have a stable troponin. Her chest X-ray did demonstrate ill-defined reticular opacities throughout the lung parenchyma, more prominent in the lower lung zones, as well as on the right. which were noted to be mildly progressed from her prior chest x-ray. And the radiologist did comment that the overall appearance was potentially concerning for a superimposed infectious process. For her abdominal pain, she did also undergo a CT abdomen and pelvis, which demonstrated an obstructing lesion at the distal left ureter, highly suggestive of a primary urothelial malignancy. So on admission, she was started on piptazo and azithromycin. She was also given 40 of IV Lasix ×1 and then resumed on her previous home dose of Lasix, 80 milligrams instead of the 40 milligrams. A Foley catheter was inserted. She did actually have a bowel movement in Emerge, after which her abdominal pain promptly improved. And she was seen both by respirology as well as urology. Urology did recommend an outpatient workup for her urothelial lesion. Respirology was of the opinion, however, that her dyspnea was likely due to her abdominal pain rather than any superimposed infection or right heart failure. Her piptazo was discontinued, but she did complete a 3-day course of azithromycin. And then initially what happened was that her creatinine actually rose while in hospital from 124 to 152, but her oxygen requirements did improve from 6 liters to 4 liters by nasal prong. So she did come back down to her home O2. At this point in time, however, she did become hypotensive, and so she was given 500 cc's of lactate ringers for this, and subsequently her creatinine then began to trend down. She did, however, continue on her Lasix at the 80 milligrams PO once daily dose. So at this point in time, the medicine team was a bit unclear whether to continue diuresis or with IV fluids, given the opposing trends in her oxygen requirements and her creatinine. And this case was, I think, especially confusing because respirology was not of the opinion that there was any component of heart failure contributing to her presentation, although her progressive shortness of breath after her oral Lasix dose was reduced, or her progressive shortness of breath began after her oral Lasix dose was reduced in the outpatient setting. This was when we were consulted for clarification of this patient's volume status and whether or not this may explain her AKI.
So we'll move on to the next part of this slideshow, which talks about VExUS and the general principles of VExUS. So what is VExUS? It's short for VExUS ultrasound score. It's a 4-step ultrasound protocol, and from the diagram here on the right, you can see you image the venous system at 4 distinct points, the initial point being the IVC, and then depending on that, you continue your exam onto the hepatic vein, portal vein, and renal veins. And the idea behind it is to try to assess whether there's any evidence of venous congestion as a result of right-sided heart dysfunction that might lead to a right-sided heart failure syndrome. So what's good about this exam, it doesn't just rely on the IVC, but it also looks at whether there's evidence of congestion within the liver, the gut, and the kidneys, and gives you a more kind of holistic picture as to what's going on. So this was the landmark trial that they, I guess, based the VExUS score on. It was done by a group in Montreal. And initially they did it in cardiac surgery patients, where they would assess how likely these people would develop subsequent AKI after cardiac surgery. And they did that by looking at Doppler patterns in people with dilated IVCs. As you can see, the results of this trial, they did have a hazard ratio of 3.7. But we'll look at some caveats as to VExUS later on, and this would be one of them, that this study was mainly done in cardiac surgery patients, and whether or not you can generalize it to the general population or patients on the medicine floor. So just some of the hemodynamic principles of VExUS. So whenever we talk about organ perfusion, usually the main focus is on mean arterial pressure. But when you talk about perfusion pressure, you're talking about inflow and outflow. So the perfusion pressure is actually a gradient between the mean arterial pressure and the central venous pressure. So you can imagine if your central venous pressure goes up, your perfusion pressure will decrease. And that's why there's this kind of thinking that, you know, we mainly focus on forward flow, arterial flow to try to perfuse organs, but not much thought is given to venous congestion and backwards flow and how this can affect organ perfusion and whether it can affect essentially organ dysfunction. So the VExUS helps us to kind of assess the venous congestion at different points in the body, and that kind of gives us a better picture. So when should I use VExUS? So it's usually most useful in patients where fluid status is kind of debated. You do have suspicion of right-sided heart failure, and it's used to help guide your fluid therapy versus diuretic therapy. I should say it shouldn't be used on its own. It's an adjunct, so it should be used in conjunction with your overall clinical picture, the biochemical analysis, the patient's overall hemodynamic status, as well as a cardiac focus to kind of bring everything together and help you make an informed decision. Here we have an image of the VExUS grading system, which we'll talk more about in a little bit. But this is kind of the overall general view of how the VExUS grading system is done. So first things first, you want to make sure you have the right machine in order to do this. So ideally, you're on the right-hand side of the patient. You can do this using either a phased array probe or a curvilinear probe. Usually using a curvilinear probe, you might have more success. You need to make sure that your machine has pulsed wave Doppler capabilities. And you can do this while the patient is supine, ideally with their arms lifted upwards in order to expose the right upper quadrant area, or crossed over to the left side. Or you can also have them slightly tilt towards the left lateral position. So step one in VExUS, it's assessing the size of the IVC and the collapsibility. So you can do that in the same kind of position from the right mid-axillary line with the probe facing towards, the probe marker facing towards the patient's head. In some patients, you can get very good views where you can image the hepatic vein, the IVC, and the portal vein all in one window, but usually that's not the case. So when you do identify the IVC, you can take a measurement then and there, and then decide whether you want to proceed on with your VExUS scan or not. Technically, if your IVC is less than 2 centimeters, then your VExUS score should be 0, and you can end your exam then and there. But again, as we know, in medicine, not everything is black and white. Sometimes you might take into consideration the overall size of the patient, whether a IVC, let's say, of 1.8 centimeters would be considered dilated in this patient. The initial VExUS score doesn't take into account whether the vein is collapsible or not. So you might want to take that into account as well before deciding on proceeding to the next steps or not. So when you do measure your IVC and it's more than 2 centimeters, you can move on to the next part of the VExUS scan, which is imaging the hepatic vein. So like we mentioned before, in that same position, you can have your probe marker facing towards the patient's head, and then you can fan posteriorly until you identify the hepatic veins. And then at that point, you can rotate your probe marker so that it's facing towards the patient's right side, or at 9 o'clock, until you see what we call the bunny ear signs. And that's the right and left hepatic vein draining into the IVC. Once you obtain that view, you can put color Doppler on, as we can see in this image here. And then it should, the color flow should generally be blue, which means blood flow is moving away from your probe and towards the heart. Once you've obtained a good image and you're in a stable position, you can put a Doppler gate roughly about 2 centimeters away from the IVC. in order to get a Doppler waveform. And then you initiate the pulse wave Doppler. And then ideally in a normal patient, you have this line here, and the Doppler tracing will trace along this line. And what this line means is whether blood is flowing towards your probe, otherwise towards the liver, or away from your probe and towards the heart. Ideally, you'd have an ECG on patients so you can kind of track the Doppler waveform with the patient's heart rate in cases that they might have arrhythmia, or if they're tachycardic. Sometimes you might get fusion of these waves. But essentially what you see is during systole, you get an S wave, so S short for systole. And then there's a transitional phase where shortly after systole, where you get a negative deflection or a V wave. And then during diastole, you get another positive deflection. And then during the atrial systole, which correlates with the P wave, you'll get this deflection here. Again, this is just another diagram which kind of goes through the cardiac cycle in conjunction with the ECG, and it shows what the Doppler waveform should be. And this waveform is kind of similar to a jugular venous waveform, where you can see there's an A wave, and then during systole you get an X descent, and then you get this positive Y, and then another Y descent, which correlates with diastole. So the hepatic waveform should mirror this jugular venous waveform when you're examining patients. So this is just another diagram kind of explaining what these waveforms mean. So initially during ventricular systole, as you can see, the right ventricle contracts, and then you should have blood flow moving away from your probe, which is pointed towards here, imaging through the liver. So that's why you get blue color on your color Doppler, and then you get this negative deflection, which is the S wave. And then during the transitional phase, which is just right after the contraction of the right ventricle, and when the tricuspid annulus moves back into its regular position, you'll get this negative deflection. And here you can see that the blood flow is flowing back into the IVC and hepatic veins, and then you're capturing this as well as a P wave. And then during ventricular diastole, when the right ventricle relaxes, it'll suck blood into the right ventricle, and then again you'll get this positive deflection away from your probe, and as blood flows through the right atrium and to the right ventricle. And then you get another negative deflection during atrial systole, where blood is kind of squeezed in both directions towards the right ventricle and towards the hepatic veins, and you get this negative deflection here, which again correlates with the ECG, as you can see here, with a P wave. The QRST part of the ECG correlates with the S and V wave, and then during repolarization, after the T wave, you get diastole, and you get this deflection of the D wave. So this is what the tracings on the hepatic vein flow should look like. So ideally, in a normal hepatic vein flow, your S wave should be greater than your D wave. And as you can see here, you have that A wave, S wave, D wave. When you get mild hepatic congestion, you'll get blood flow flowing backwards, and then you'll get your S wave will shrink in comparison to your D wave. So you can see here that the S wave is shorter than the D wave segment. And then when there's severe congestion, you'll get reversal of the S wave, and you'll get a negative deflection towards your probe. And as you can see here, it's total just S and D waves, and there's nothing in between. So again, looking at this diagram, this kind of helps explain it a little bit better. So we have the atrial, the A wave, the atrial systole, as we kind of talked about. It pushes blood in both directions, and that's why you get this deflection here. And then in the setting of severe tricuspid regurgitation during systole, if you have tricuspid regurg, as you can imagine, when the right ventricle is squeezing blood out, a large portion of that blood will flow back into the tricuspid valve and then back into the hepatic veins. And that's when you start seeing this shrinking of the S wave. And then when it's severe to a certain point, you'll get complete reversal of the hepatic waveform here, where the V wave is giving you a negative deflection. So sorry, the S wave is giving you a negative deflection. So once you obtain your waveform for the hepatic vein, you move on to the portal vein, which again, when we talked about, you're in that same position, you kind of fan anteriorly until you see the portal vein, which has a bit of echogenicity towards around the walls of it. And that kind of tells you that it's a portal vein. And then you can confirm this by putting a color Doppler on it, and you should get a red or orange colored waveform, which means that blood is flowing towards your probe, which should be normal in a portal vein. So once you obtain this image, you can put a pulse wave Doppler gate on it and then initiate your waveform. Ideally, in normal patients, what you should get is this kind of continuous waveform, which is called a venous hum. And then you calculate the maximal velocity and the minimal velocity, and then you can calculate a pulsatility index. So that's the Vmax minus the V minimum, and then divided by the Vmax. In normal patients, it should be less than 30%. If there is mild congestion of the portal vein, you'll get anywhere between 30 and 50%. And then if there is severe congestion, you can see that the waveform here, the difference between the Vmax and the Vmin, it's more than 50%. In some cases, you can also get a deflection below the baseline if it's severe to that point. And then again, it's always useful to have the ECG on top of here, and you can kind of trace these waveforms in accordance with the patient's rhythm. Moving on to the next step, this is the hardest part of doing a VExUS scan, is getting an intrarenal venous Doppler. And the way to do that is by identifying the kidneys. You can technically do it while you're still in that same position, and you try to aim a bit posteriorly until you can visualize the kidneys. Once you do that, it's generally better to have the probe marker facing towards 3 o'clock. So you get the kidney in this kind of position. And then you can put color Doppler here on it to try and visualize the intralobar vessels. Here it's difficult to make a distinction between what's flowing towards and what's flowing away from the probe. And generally, we need to turn down the scale of the color Doppler here in order to pick up the slower velocity of blood flow through the kidneys. Once you do obtain a good image, you can put a Doppler gate on the intralobar vessels and then initiate pulse wave Doppler. Ideally, in normal patients, what you should get is this above this baseline here, you're seeing an arterial waveform, but you're not really interested in that. But that kind of, you can use it to help you correlate with the underlying venous waveform is what we're looking at. So ideally, in normal patients, you should get monophasic flow or a continuous kind of flow. With mild intrarenal congestion, you'll get splitting of an S wave and D wave, and get biphasic flow during systole and diastole. And here you can appreciate that you get help from this arterial waveform as well, because this can help you, because you can see here is when systole is occurring, and you can see, you can make that distinction that between systole and diastole, there's interrupted blood flow in the venous system here. And then when it's severely congested, all you'll get is this diastolic flow without any systolic flow. So putting it all together is the VExUS score is you measure at 4 different distinct points looking for venous congestion. Step 1 is measuring the IVC if it's more than 2 centimeters, and then you proceed on to the next steps, which is the hepatic vein Doppler, portal vein Doppler, and renal vein Doppler. Depending on whether this is normal, mildly abnormal, or severely abnormal, you can allocate points to it, and then you can kind of make your grading based off of that. So if you have an IVC congestion of more than 2 centimeters and any combo of normal or mildly abnormal, this is considered grade 1 congestion. Grade 2 is dilated IVC and 1 severely abnormal pattern. And then grade 3 is dilated IVC and 2 severely abnormal abnormal patterns. I'd say generally this grading system doesn't make much of a difference because whether someone is mildly congested or severely congested, your approach to them is going to be the same.
So now applying VExUS to our case, we can see that here Ms. Giu's IVC is 2.23 centimeters. So she does make that 2 centimeter cutoff. And according to the VExUS grading system, there has to be at least grade 1 or mild congestion occurring here. But as you can see in this video clip here, it is actually quite collapsible, definitely more than 50%. But we know that the VExUS grading system doesn't incorporate that. Looking at her hepatic vein Doppler, so here you can see that nice bunny ear sign with the hepatic veins pouring into the IVC. And according to the Doppler tracing here, her S wave does appear to be larger than her D wave here. And so we would grade this as normal hepatic vein flow. In terms of her portal vein Doppler assessment, so looking at the Vmax and Vmin here, it's safe to say that there's probably less than 30% variation between these. And so she does have a normal pulsatility index of less than 30%. And then finally, for the intrarenal venous Doppler assessment, you can see nice monophasic flow here. Which once again suggests, no renal congestion occurring. So ultimately, based off of her VExUS findings, she gets a grade 1, given her IVC was greater than 2 centimeters and her normal the remaining normal venous Dopplers, overall suggesting mild congestion, as we mentioned. As we said, this doesn't account for the respiratory variation in her IVC. And furthermore, we know that she has a history of pulmonary arterial hypertension. And when we compare to her previous echo, which noted a right atrial pressure of 8 and an RVSP of 30 to 40, which was consistent with our cardiac POCUS, it's therefore quite unlikely that there's any acute venous congestion occurring, which would not be in keeping with an acute decompensation of her heart failure. Regardless, she did have a normal intrarenal venous Doppler. So this is probably unlikely or venous congestion or a cardiorenal syndrome is unlikely to explain her AKI in this setting. So we did recommend that the medicine team consider alternative etiologies for her AKI.
Yeah, so we'll talk about some of the caveats and limitations to VExUS. So sometimes in patients with increased intra-abdominal pressure, you might get compression of the IVC, and that does not necessarily entirely mean that the IVC on its own wouldn't have been distended and non-collapsible. In patients with chronic pulmonary hypertension, the RV and the RA can experience some forms of remodeling, and as a result of that, they might develop compliance. And even in the setting of TR, you might have normal tracing hepatic vein flow. Conversely, also in people with severe TR, you might always get a abnormal tracing of their hepatic vein waveform, which needs to be taken with a grain of salt. And that's why doing serial VExUS scans can be helpful in people you're suspecting have congestion. So assessing and then reassessing after decongesting, and then looking at the different organs that we or the different veins and different organs that we image can help bring together a more kind of complete picture. The portal vein can display pulsatile flow, especially in thin, healthy subjects. So it doesn't necessarily always mean that that's abnormal. And in patients with advanced fibrosis or liver cirrhosis, the transmission of pressure from the right atrium can be dampened down by the liver sinusoids and may lead to non-pulsatile flow, even though they have severe congestion. Also, intrarenal Doppler is probably the most technically difficult part of this scan, and you may get suboptimal results as a result of this, and you may misinterpret the findings. And parenchymal renal disease may also alter your intrarenal Doppler waveforms. So, and then also what we talked about before is that the VExUS grading system was mainly validated in patients to predict AKI in cardiac surgery patients. So again, it's kind of tough to say whether we can generalize this to the general population or not. And then probably one of the issues we encountered most during the time doing VExUS is interpreting it in patients with arrhythmias such as atrial fibrillation, complete heart block, and so on. Sinus tachycardia, because sometimes you get fusions of waveforms or you get incomplete waveforms. And those need to be interpreted with caution and ideally having an ECG on board at the same time to kind of help you make distinctions of what are when is systole occurring and when is diastole occurring. So again, as in anything with medicine, it has its caveats, and you need to recognize the limitations of doing such a study. And it, like we said before, it shouldn't be done on its own, and decisions shouldn't be solely based on this, but with the whole clinical picture in mind altogether.
So coming to our second case, this is Mr. J.M. He's a 69-year-old male from home with partner in London who presented to hospital with shortness of breath on exertion, progressive pedal edema, abdominal distension, and generalized weakness. This is in the setting of a past medical history of alcoholic and NASH cirrhosis. He, in terms of decompensating features, does have one small low risk varix on EGD, which was identified in January of 2022, so just this year. He's a child's Pu-A cirrhosis with a MELD score of 10. He otherwise also has hypertension, dyslipidemia, and he's on Lasix 20 once a day, amlodipine, hydrochlorothiazide, and rosuvastatin. So he presented to hospital with a 2-week history of progressive shortness of breath on exertion, an NYHA class of 3, with progressive abdominal distension and pedal edema as well. And he also did endorse significant trouble breathing while flat, so maybe some orthopnea going on. On presentation, he was quite tachypnic with a resp rate of 30 and was satting 98% on 4 liters by nasal prong. On auscultation of his lungs, there were bibasilar crackles. He also did have a grade 2 to 3 pitting edema bilaterally to his knees, and his abdomen was quite distended with a query fluid wave noted. His blood gas, CBC, LFTs, liver enzymes, creatinine, and electrolytes were all either normal essentially or stable from previous values. His ECG did, however, show new AFib with rapid ventricular rate. He did reassuringly, however, have a fairly stable troponin. His chest x-ray showed small bilateral dependent pleural effusions with possible atelectasis at the right lung base, but no frank pulmonary edema. And he was also noted to have a enlarged cardiac silhouette, which was appreciated on previous x-rays. So on admission, he was initially given a one-time dose of 60 IV of Lasix and then started on 40 IV BID. To everyone's surprise, his abdominal pocus actually did not show any ascites. And so at this point in time, the possibility that his presentation was in keeping with heart failure rather than cirrhosis became more likely. In terms of his cardiac POCUS findings, so we did actually note that he had a dilated and dysfunctional right ventricle with tricuspid regurgitation and an estimated pulmonary arterial systolic pressure of at least 50 to 55 millimeters of mercury, and this was not noted previously on his chart. He also had a normal left ventricular systolic and diastolic function and no left-sided valvulopathies, as well as a normal left atrial pressure. In terms of Mr. JM's IVC, so you can see here that it was 2.24 centimeters, and in his case was not very collapsible. I'd say less than 50%. And so we proceeded with his remaining VExUS score. Here, his hepatic vein Doppler was a bit difficult to interpret. He was in atrial fibrillation during this assessment. And so overall, we did give him, score this as essentially indeterminate, but if we were to look at his waveform, and we do see those negative signals above the baseline, which in the context of atrial fibrillation, you wouldn't get a nice A wave representing the atrial contraction. And so we could postulate that maybe those negative waveforms there are actually S waves signifying S wave reversal, and therefore a severely abnormal pattern. Interestingly, we did see that his portal vein pulsatility index was less than 30%. But as Maytham mentioned, in liver cirrhosis, pressures from the right atrium might not transmit due to the liver sinusoids, and therefore you may not actually have, or you may actually have a normal pulsatility index despite congestion. And then here we can see that he does have a biphasic pattern to his renal vein Doppler tracing there, giving him a mildly abnormal score there. So putting it all together for his case, from our POCUS, we identified that he has a dilated right ventricle with mildly reduced systolic function, elevated estimated pulmonary arterial pressures. And depending on how you grade his hepatic vein Doppler, either grade 1 for grade 2 for S wave reversal, so a severely abnormal pattern, or you just grade it as indeterminate and essentially don't include it in the score. He has either grade 1 or 2 congestion as per his VExUS, and clinical signs and symptoms consistent with heart failure. So overall, we did think that his picture was concerning for decompensated right heart failure, and we recommended that the team continue ongoing diuresis. So the nice thing about this case is, as Maytham was mentioning, VExUS was a really nice adjunct to use with his other imaging, his clinical history, physical exam, and lab work to kind of paint an overall picture convincing of decompensated right heart failure. Now we'll just open up the floor for any questions or any comments for discussion.
Hey, Maytham and Maria. Sorry I was late. It's Mike here. Great. I caught the second case and halfway through the resolution of the first one. Really great job for what I saw, and then I'll go back and watch the rest of it later. Just a quick question about that second case. Did that gentleman go on to have any imaging to rule out PE?
He did, and he wasn't noted to have any PE. He did have a dilated pulmonary arterial trunk though. So even on CT thorax, they did comment about the possibility of pulmonary hypertension.
Perfect. Yeah. So I mean, it's a great case. I think, you've already talked about the caveats with the AFib, difficulty interpreting some of the waveforms. And I think the other thing that's always important is just not getting too, tunnel visioned when we're doing these assessments, and making sure that, someone comes in, elevated RVSP, but a dysfunctional right ventricle, thinking about the common things being common, and ruling things like PE out before jump into just diaries and call this new pulmonary hypertension and right heart failure. But awesome case. It'd be interesting to see if the renal vein Doppler and everything there improve with diuresis.
Mm-hmm.
Yeah. On the point of improving the Doppler flow with diuresis, I think that's also a very excellent use of the VExUS scan. Sometimes with ongoing congestion and diuresis, even though if there is clinical improvement, it's sometimes hard to know where the endpoint would be for your diuresis, and potentially, although not validated or extensively studied just yet, using VExUS as an endpoint for your diuresis could be a possibility.
Yeah, I think the more and more we do VExUS, the more we're realizing that it's beneficial when used serially for serial reassessment, having a good baseline, and then being able to compare congestion from your baseline scan and how things improve with either diuresis or other volume like CRRT, for example.
Are there any other questions? Oh, Dr. Renuka.
Hi, sorry. Yeah, excellent presentation. It was very refreshing and good cases. Every time I noticed that the hepatic vein Doppler was integrated, it was almost not parallel, and the pulse was kind of 60 to perpendicular. So that was also one of the things you'll have to try your best to improve the image such that you find the vein blood flow more parallel to your introgation, because every time I noticed it was almost kind of perpendicular. And otherwise, excellent case and good review. And yes, what Michael said was very important, that the best option is prognosis and to assess the prognosis and follow up. Yeah, thanks. It was nice.
Thank you.
If there are no further questions, maybe we'll call it a day today. And thank you once again, Maytham and Maria, for presenting.
Awesome job.
Great.
Thanks.
Thank you for listening, guys.
Thanks.
Bye.
Bye.